I'm just telling you that there's a massive amount of what physicians are required to do now that detracts from what it is that only they can do. There's a question that I taught myself to ask myself. What is it that only I can do? And the thing that it is only I with the patient that can give my undivided attention to them, to think deeply about the complexity of their cases. There are a lot of other things that physicians are required to do that it's not that it's beneath physicians to do it. That's not the issue. The issue is that it's taking time away from that deep reflection that physicians need to be able to do to give themselves undividedly and unreservedly to the patient in front of them. And there are some things that only physicians. Now, okay, let me also disclaim. So I'm an MD, so I tend to say physician, but what I mean is practitioner. It's just that it's a little more awkward. So I mean anyone who's attending patients at the bedside. So physicians are my tribe, so I default to that word, but I want to make sure that I'm inclusive and make sure you know that I'm talking about anybody who is there at the bedside of patients. Okay, so disclaimer, I should have said that at the beginning. So there's a concept in medicine called SCUT work. Do you guys know about SCUT? Okay, all right. Anna, do you know about SCUT yet?
I do.
Okay, Anna Berry is another student of mine. She's at Baylor College of Medicine, so be sure and say hello to her. She was in medical humanities too. So SCUT is the slang term that we mean for menial tasks or the work of a useless person. Okay, that's the definition, the work of a useless person. So there's a doctor named Stephen Petrani who made the connection between SCUT work and what I'm talking about. And what he says is so SCUT work used to look like this. Instead of delicately searching for subtle veins of the forearm as a source of blood, or residents now search a cornucopia of tabs on a computer screen, hoping to identify the proper heading to draw upon needed information. Instead of inserting IVs in severely dehydrated patients, residents now insert lists of data points that support billing levels and required quality metrics. Instead of studying algorithms that guide approaches to complex patients, residents now have to memorize specific electronic workflow patterns. So this is another kind of SCUT work, is what this is. And it takes away from attention to the patient. So I want to show you some of the things that I have come across, some of the examples. And what I started doing was I started taking screenshots of some of the absurd things that I see. And so if you come find me on Twitter, it's one of my favorite things is to show you screenshots of things that you would not believe me if I told you there was a code for, what is it, fire?
Water skis on fire.
Water skis on fire. There's a code for water skis on fire. I have it's true. There's a code for spacecraft accident. I've never used it. I'm sure somebody has used that code, but I haven't used that code. This is an example of just the kind of stuff we're talking about. Again, I wanted to show this screen as an example of just how much data is coming at you at one time. I wanted to show you this. Now, this is not an actual patient chart, but again, I wanted to show you just try to take in this much information. And that is a lot on one screen. I wanted to show you this. This is fascinating. So this is fracture of the arm. You know, arm, it's a humerus fracture. And this is a fraction of, pun intended, a fraction of all the codes that go with an arm fracture. And what I want you to note here is how much time it takes a doctor to scroll through there. And this is what I want. This is what I really want you to see. How many of these numbers are the same? So you've spent all this time over here picking the right code, and then I realized after years, wait a minute. I spent all the time picking this specific code, and a lot of the numbers are the same. Okay, let me show you this one. So the next one I'm going to show you, I needed to order a toe x-ray. And of course, I know I need to put right or left, of course, all right? But and then it asked me which digit. Well, I've never seen one toe x-ray without the other 5 toes on the x-ray. I've never seen that happen. But I guess it could happen. So I know which one I want, and I can't remember at the time, but there's a certain way that we number the anatomy. So this would be 1, 2, 3, 4, 5. That's the way, there's no other way to number things. Except when this came up, I felt for the first time what it must have been like to have a stroke. Because this is what came up. Fifth, first, fourth, second, third. Now, I know I want second, and I know I'm looking at the word second, but there's something in me. I can't, I mean, it was just like a glitch. I mean, I just crashed. My hard drive crashed. And then I realized someone has spelled these words out, and then what? Put them in alphabetical order. They put them in alphabetical order. So these are the kinds of things. I am not making this up. And on the one hand, you might think, okay, whatever. I mean, come on. It's not. But magnify this. Magnify this over and over and over and over and over again. Absurdity like this. Over again. And it is no wonder that doctors are burning out. I mean, it's no wonder. This is not what we went to medical school to do. I always felt like when I heard doctors say that they were complaining or whining, but this is not complaining and whining. This is what's taking doctors away from patients, and this is not acceptable. Here's another example, all right? So what I want you to see again is how much information is here. Just, you know, I mean, I know it's not necessarily meaningful. It's got my name 3 times. It's got the nurse who ordered it. It's got where we are. It's got what it is. It's got the final result. It's got, you know, it's got all this on it. Guess what I need? I need that word in the middle that says negative. I just need NEG or POS. That's all I need. And so this is like the simplest test there is. And yet, when I'm confronted with this paper, that is a lot to filter through, to discard. I'm having to discard most of it, and I'm having to find, and the result isn't even the biggest thing on there. I mean, that would be a simple design fix. Just make it the biggest thing on there. So that's another example. So what I'm trying to illustrate is the work of physicians that's been shifted on, the documentation work that's been shifted onto doctors, that's taking them away from real doctoring. And the doctors don't like it, and patients obviously don't like it. So what I want to talk about now is how can our awareness of the message in the media that we're talking about and the way it has altered and distorted human interaction in the exam room, how can we modify that message? What can we do? So I recognize that there's tremendous potential in the EMR. I mean, I type over 100 words a minute. I don't have a problem on a keyboard. And I even am able to type while I'm talking to patients. I don't like to do it, especially if it's a clackety keyboard. That is so rude. Why keyboards? You know, you guys know what I'm talking about, right? Why can't it be a nice, quiet keyboard instead of clackety? So these are some examples. I want to give you some examples of steps I think we can take. So one is to minimize the intrusion of technology as much as we can. We need to disappear the technology as much as we can. We need a Steve Jobs for the electronic medical record to streamline, and I really believe it's a design issue. Some of you may not know, you might think about, well, why aren't programmers doing, you know, why aren't programmers presenting the information? They don't do that. Programmers code. So the design or the interface, the presentation of the interface to the user is a completely, it's hard for me to believe it, but it's a completely separate function. And so I really believe that there's a huge need for people, for designers, people who are going to work specifically on the interface between physicians, practitioners, and their technology. That's what we need. So we need to minimize the intrusion. We need to minimize the mistakes. And I'm not even talking about the hardware problems that are constantly intruding, message errors, falling off the network, and that sort of thing. Put the priority of the EMR on the practitioners and not what's convenient for the programmers. Okay? Practitioners and programmers need to be working together to create the best interfaces, and physicians need to be intimately involved with those designs. I know, I can't point to the research, but I recognize the massive cognitive load that the EMR has on doctors. Like I said, having to discard all of that information. You have to look at it, and you're always worried you're going to miss something, but you have to take it in and then discard it, and that is a huge cognitive load for physicians, and it's causing a lot of burnout. We need EMRs that are customized for specialty, for setting. We need a keen eye to the design of the environment. So, you know, there are always going to be monitors in exam rooms and computers in exam rooms, but there's sometimes when I am in exam rooms where my computer here and the only chair for the patient is way on the other side of the room. So we need a keen eye to the design of the physical space of the exam room that maximizes human contact. And something that I do is I want to always make sure in every encounter that I have uninterrupted eye contact with the patient and that I lay my hands on them. And I'm very intentional. I love what you said about boys. I'm very intentional about the laying on of hands. And I just think that it's crucial, it's central, it's ancient, but it's never going to be outdated. And the laying on of hands and making sure that you carve out space and making sure that physicians carve out space in the encounter where they are locked on and giving themselves undividedly to the presence of the patient, I think is crucial. And even if you're not able to do that for the whole, you know, ridiculous 7 minutes that we're given to take care of patients, which I completely revolt and find ways all the time to, you know, peacefully protest that. And passive resistance, it's all about passive resistance. And the other thing that I try to do is if I have to look at the screen, my preference is to look at the chart before I go into the patient's room. And then my preference is to do everything I can without opening the electronic record and then doing the charting after. But what that ends up meaning is I've got 3 hours of documentation to do after everybody's gone home. And that's no fun either.